So today's topic is paraneoplastic syndrome. What are paraneoplastic syndrome? Paraneoplastic syndrome are heterogeneous group of disorders associated with cancers, but not due to direct invasion, obstruction, or mets caused by an aberrant release of humoral mediators such as hormones like peptides, cytokines, and antibodies. Epidemiology. Paraneoplastic syndromes can occur in both patients with small and non-small cell lung cancer. It is seen by 7 to 15% of all patients with lung cancer. Systemic symptoms and finding of paraneoplastic syndrome develop in 50% of patients with small cell and almost 10% of patients with non-small cell lung cancer. So whenever we are looking at a patient with a cancer, we have to identify the local tumor effects and the symptoms caused by cancer itself and its metastatic spread. And second, we need to look out the paraneoplastic syndromes associated with the malignant diseases. For example, the notable ones: Cushing syndrome, SIADH, hypercalcemia, finger clubbing, Lambert-Eaton syndrome. The important ones. We'll discuss one by one each of them. So, as we are only discussing a paraneoplastic syndromes associated with lung cancer, let's begin. So, the paraneoplastic syndromes associated with the small cell lung cancer are SIADH. SIADH causing hyponatremia, increased ACTH causing Cushing syndrome, carcinoid causing flushing and diarrhea, Lambert-Eaton syndrome, and superior vena cava obstruction syndrome. Squamous cell cancer like PTHRP causing hypercalcemia, Horner syndromes causing ptosis, meiosis, and hydrosis, Pancoast tumor, first and second thoracic nerve involvement causing shoulder pain, ulnar nerve pain, adenocarcinomas causing pulmonary osteoarthropathy or mesenteric endocarditis. And last, large cell cancer causing SVC syndrome and gynecomastia. In summary, lung cancer paraneoplastic syndrome can cause ophthalmic, paraneoplastic associations, hematological, endocrine, neurological, dermatological, rheumatological, and so on. The notable effects in endocrine, as we discussed, SIADH, hypercalcemia, carcinoid syndrome, hypoglycemia, acromegaly, neurological, encephalitis, cerebellar degeneration, LEMS, Lambert-Eaton myasthenic syndrome, stiff person syndrome, opsoclonus myoclonus syndrome, rheumatological, hypertrophic pulmonary osteoarthropathy, inflammatory myopathy, ophthalmological, retinopathy, and optic neuropathy. In nephrological involvement, remember membranous neuropathy, and hematological, granulocytosis, thrombocytosis, venous thromboembolism, and paraneoplastic anemia. What are the mechanisms? So, associated cancers Paraneoplastic syndromes and their mechanisms. For example, the hypercalcemia happens in squamous cell cancer, and the mechanism behind it PTHRP, SIADH in small cell lung cancer because of ectopic ADH secretion, Cushing syndrome because of carcinoid tumor and small cell lung cancer, ectopic ACTH secretion, acromegaly, carcinoid small cell, bronchoalveolar carcinomas, epidermoid carcinomas, etc. because of ectopic growth hormone releasing hormone, and insulin-like growth factor. Carcinoid syndromes in carcinoid tumors and small cell lung cancers, these are serotonin-mediated, gynecomastia, non-small cell lung cancer, adenocarcinoma, especially by estrogen secretion. Hypoglycemia, mesenchymal tumors, carcinomatoid carcinoma, insulin-like growth factor 2. So let's discuss hypercalcemia in detail. It is reported in 2 to 6% of lung cancer at the time of initial diagnosis. Incidence increases to 8 to 12% over disease course. It can be seen in other cancers as well, like breast carcinoma, renal, multiple myeloma, lymphoma, lung cancers like squamous cell carcinoma. Causes we have already discussed. Clinical features of hypercalcemia. So it could be gastrointestinal side effects like nausea, vomiting, abdominal pain, and constipation. Neuropsychiatric symptoms like fatigue, lethargy, mood changes, cognitive dysfunction, renal side effects like polyuria, nephrolithiasis, nephrogenic diabetes insipidus, or cardiogenic side effects, arrhythmia, short QTc interval. How we diagnose? So calcium level will be high, more than 2.6 millimoles per liter, or if we are taking in milligrams per dl 10.5, we classified them into mild, moderate, and severe according to the symptoms and the levels as well. How to treat hypercalcemia? If it is mild, no treatment is needed, just remove the supplements from the patient prescription. If the patient is symptomatic or the levels are high, the first line of treatment is IV fluids. If it is not treated by that, we can follow it with the loop diuretics or bisphosphonates like pamidonate or zolindonate and denosumab. Second line treatment like calcitonin can also be initiated in some cases. SIADH is the second topic. We'll discuss in detail. It is a state of euvolumic hypoosmolar hyponatremia secondary to ectopic ADH secretion, characterized by low serum osmolality and inappropriately high urine osmolality in the absence of diuretic treatment, adrenal insufficiency, heart failure, cirrhosis, or hypothyroidism. Small cell lung cancer 10 to 45%, non-small cell lung cancer less than 1%. We'll discuss the diagnostic criteria of SIADH. Hyponatremia less or equal to 135 milliequivalents per liter. Low serum osmolality less than 275. Euvolemia, urinary osmolality of more than 100, urinary sodium of more than 40 with normal dietary sodium uptake, normal thyroid and adrenal function after excluding renal function, no recent use of diuretics. Supplemental features could be like a plasma uric acid lower than 4 mg per dl, B1 less than 10 mg per dl, and correction of hyponatremia through fluid restriction. Causes of SIADH: neoplastic, more in carcinoid, then in small cell lung cancer, and then in mesothelioma and other cancers. It could occur in other pulmonary diseases, infections as well, as mentioned here, certain CNS disorders, and some drugs can also cause SIADH. What is the treatment? It also depends upon how patient symptomatic, and the level of sodium which are low. So rapid decline, severe symptoms less than 120 milliequivalents per liter. If the patient is having cerebral edema, it can present with headache, irritability, restlessness, hyporeflexia, confusion, coma, seizures, brainstem herniation, and death. You can start with a water restriction, 3% sodium, hypertonic saline, diuretics and oral salts, vaptins like tolvaptins and convaptins. So the third is ectopic Cushing syndrome. It also occurring in a small cell lung cancer, 30%. Bronchial carcinoid tumors less common. Clinical features of ectopic Cushing syndrome are moon-like face, acne, purple striations, proximal muscle weakness, peripheral edema, hypertension, metabolic alkalosis with hypokalemia. Almost all ectopic Cushing syndrome patients show hypokalemia and hyperglycemia. However, ectopic Cushing syndrome secondary to small cell lung cancer really exhibit all of the classic signs of Cushing syndrome. Diagnostic criteria for ectopic Cushing syndrome: cortisol will be high, exclusion of iatrogenic hypercortisolism, elevated morning ACTH. In absence of pituitary tumors on imaging like CT or MRI, surgical excision of the tumor, or we can try some medicines as well like ketoconazole and metyrapone can be used to decrease the cortisol synthesis. Now, hematological paraneoplastic syndromes. So they can be occur in non-small cell cancer, granulocytosis. The mediators are GCSF, GM-CSF and IL-6. Thrombocytosis can occur in small and non-small cell lung cancer. The mediator is IL-6. Thromboembolism, non-small cell lung cancer or small cell tissue factor, cancer procoagulant factor. Granulocytosis in the absence of infection or leukemia is relatively common at the time of diagnosis or during the follow-up of patients with lung cancer, seen in 14.5% of patients with lung cancer, and the majority. Granulocytosis develop due to the production of paraneoplastic hematopoietic growth factor and certain IL-6. No specific treatment required other than the cancer treatment. Anemia is seen in several types of cancer. It occurs as a paraneoplastic syndrome in cancer patients and it is a normocytic normochromic anemia. This condition presents with low serum iron levels and normal or elevated ferritin levels, normal iron stores and low serum erythropoietin levels. In lung cancer, anemia as a paraneoplastic syndrome may also develop depending on the autoimmunity known as autoimmune hemolytic anemia. Although antibodies with the specific associations are unknown, generally recovers after the cancer treatment. Venous thromboembolism, more common with non-small cell as compared to small cell, and especially more common in adeno as compared to squamous. Treatment with subcutaneous low molecular weight heparin should be considered for the first 6 months over vitamin K antagonist. Extended anticoagulation beyond 6 months should be considered for indefinite period or until the cancer is cured. Edoxaban, rivaroxaban can be used as an alternative. Low molecular weight heparin for those with high risk of bleeding, or vitamin K antagonist reserved for patients with contraindication to the low molecular weight heparin drugs or unaffordable. Important. Neurological paraneoplastic syndrome. Paraneoplastic neurological syndromes are neurological disorders caused by the remote effect of cancer and they are not caused by the tumor itself. These are basically occurring because of antibodies. onconeural antibodies and the associated onconeural antigen-specific T lymphocytes inadvertently attack both the components of nervous system and the tumor cells. As you can see, the neurological paraneoplastic syndrome mostly occur in small cell lung cancer. So we can safely say that most of the neurological paraneoplastic syndrome in lung cancer patients are associated with small cell lung cancer. The important ones are encephalomyelitis, limbic encephalitis, or subacute sensory neuropathy, anti-HU antibodies. Others are paraneoplastic cerebellar degeneration, opsoclonus and myoclonus, cancer-induced retinopathy, Lambert-Eaton syndrome, and stiff person syndrome. What are the mechanisms of paraneoplastic neurological syndrome? So they are sensory loss, spinal cord or dorsal root ganglia, behavioral loss, memory loss, seizures, limbic system, nystagmus dysarthria involvement, brainstem involvement, involuntary eye movement, dentate nucleus, autonomic dysfunction, nerve terminal, proximal muscle weakness, neuromuscular junction, photosensitivity and visual field sarcoma photoreceptor. Treatment is with IVIGG. Plasmapheresis are being used along with the treatment of primarily disease. Encephalomyelitis is the important one. Patients with encephalomyelitis exhibit a relevant clinical dysfunction. The term encephalomyeloneuritis and encephaloneuropathy have also been used to describe this terminology. The main clinical syndrome observed in encephalomyelitis are subacute cerebellar degeneration, myelitis, limbic encephalitis, brainstem encephalitis, subacute sensory neuropathy. Let's discuss limbic encephalitis. It may be suspected with acute or subacute progression over the period of several days to months. Symptoms include most important personality changes, irritability, depression, seizures, memory loss, confusion, and sometimes dementia. 20% of limbic encephalitis cases are associated with neoplasms. In a study of 50 paraneoplastic limbic encephalitis patients, 50% had lung cancer, including 40% of small cell lung cancer patients and 10% of non-small cell. So that's very important. Anti-HU antibodies are found in 36 to 50%. Anti-MAC2 antibodies are found in 20% of patients. How we are going to diagnose them? EEG findings include focal or generalized slow activity, epileptic activity in the temporal lobe. This is important. MRI findings revealed high signal intensities in unilateral or bilateral temporal lobes in 70 to 80% of patients using with T2 emphasize or FLAIR image. CSF analysis has been reported to show the evidence of inflammation, including pileocytosis, elevated protein, elevated IgG, and oligoclonal bands. In 80% of limbic encephalitis patients and may support the clinical diagnosis. Treatment: treat the underlying cause. Therapy for underlying small cell cancer is the best treatment for paraneoplastic, although immunosuppressive therapy is sometimes encouraged, but treatment of the underlying cause will improve the symptoms. Now, Lambert-Eaton myasthenic syndrome. It is a presynaptic disorder of neuromuscular transmission characterized by impaired release of cortical acetylcholine release. Clinical features include proximal muscle weakness, depressed tendon reflexes, post-tetanic potentiation, as well as autonomic changes. Approximately 50% of patients with Lambert-Eaton have a tumor, and it is associated mostly with the small cell lung cancer. Approximately 3% of the paraneoplastic in the small cell is a Lambert-Eaton myasthenic syndrome. It should be differentiated from myasthenia gravis, as Lambert-Eaton myasthenic syndrome have depressed or absent reflexes, experience autonomic changes such as dry mouth and impotence, has incremental rather than decremental response on repetitive nerve stimulation. Diagnosis: first of all, the features: proximal muscle weakness, autonomic symptoms, reduced tendon reflexes, then favorite in most of the BCQs, anti-voltage gated calcium channel antibodies. Repetitive nerve stimulation abnormalities, low compound muscle action potential, decrease more than 10% at low frequency, increase by 100% after maximum voluntary contraction or at high frequency. Treatment: treat the underlying cause, but 3,4-diaminopyridine has been used as a first-line treatment for the patients with a symptomatic Lambert-Eaton myasthenic syndrome. This agent blocks the voltage-gated calcium channels and prolongs the opening of channels and the action potential at terminals of the motor nerves. Starting dose is 5 to 10 milligrams 3 to 4 times per day, and the maximum we can go of 60 to 80 milligrams per day. Other than that, pred and azathioprine for long time might be chosen if the symptoms remain, or IV immunoglobulins may be given if the patient is having crisis. Rheumatological paraneoplastic syndrome, clubbing, 4th grade, that is hypertrophic pulmonary osteoarthropathy, mostly in adenocarcinoma, non-small cell cancer. The mechanism is vascular endothelial growth factor or platelet-derived growth factor. Second is inflammatory myopathy, more common in small cell as compared to squamous, ANA, anti-Jo1 antibodies. Hypertrophic osteoarthropathy is a syndrome characterized by finger clubbing and periostitis. Lung cancer more than CF and TB can also be a causes. In lung cancer, non-small cell adenocarcinoma has more percentage, but high incidence are observed in solitary fibrous tumor of the pleura. Platelet-derived growth factor, vascular endothelial growth factor, PGE2 are the key mediators. Clinical features are arthritis and joint effusion and pain, subperiosteal new bone formation and clubbing. Tramline, double stripe sign, and TC99M MDP, methyl diphosphonate scan. Treatment: NSAIDs, octreotide, or in some cases, vagotomy or an alternative treatment apart from the treatment of the primary lung cancer. Now, dermatological syndromes. Common syndrome: paraneoplastic acanthosis nigricans. It is a gray-brown symmetric velvety plaques on neck, axilla, flexor areas, and anogenital region. The tumor associated with it are non-small cell lung cancer, gastric and adenocarcinomas, and the cause is IGFR abnormality, as you can see here. Second is triple palm. Triple palm is a hyperpigmented, velvety, thickened palms with hyperkeratotic ridges. More common in non-small cell lung cancer. Abnormality is same, IGFR abnormality. Then pachydermoperiostosis, thickening of the skin, lips, ears, lids, scalp, excessive clubbing. Same, non-small cell lung cancer, IGFR abnormality. Now coming to some rare disease, acquired hypertrichosis languinosa, cutaneous paraneoplastic syndrome characterized by development of excessive, long, fine, non-pigmented hairs, preferentially located on the face, as you can notice here. colorectal lung breast cancers and FGF or acrokeratosis appears as erythematous papillosquamous plaques on the nose, ears, and less frequently on fingernails, hands, feet, knees, and elbows. More common with oropharynx and larynx but can occur in lung cancer as well. Now, nephrogenic paraneoplastic syndrome. Membranous nephropathy is the one word which need to be remembered. Or nephrogenic paraneoplastic syndrome involves a group of disorders that develop as a result of glomerulopathy, which may cause electrolyte imbalance and urea creatinine elevation, leading eventually to renal failure. Others are minimal change disease, focal segmental glomerulosclerosis, IgA nephropathy, and membranoproliferative glomerulonephritis. Ophthalmological paraneoplastic syndromes related to the retina or optic nerve can be seen in lung cancer cases, particularly in small cell and retinopathy, and optic neuropathy may develop and result in visual dysfunction. The mechanism is immune reaction, and antigens are associated are recombinant alpha enolase, whereas collapsin response mediator protein 5 is the antigen associated with paraneoplastic optic neuropathy, and treatment is primarily on immunosuppressive therapies. However, visual functions may not improve despite immunosuppressive therapy. Ineffective treatment of underlying cancer, so treat the cancer is the treatment. Then cachexia and fever can also occur.